What are your thoughts about narcotic painkillers, and do you think that they inhibit the healing process? Okay, so this is a big issue right now. I mean, we hear all the time, it's in the news, it's everywhere, there's this opioid epidemic going on. Just the other day, there was an article about how more people are dying from opioid overdose than heroin, which is crazy, right, in our society. And so I think the onus falls on the physician to really look at their protocols. And there are a lot of issues with narcotics. So from my standpoint, it's not so much that I'm worried about dependency, because we really screen patients for that and work on getting them off of that. It's how does it affect you after surgery? And so for me, it's not so much the pain control issue and the dependency, it's that opioids have a lot of side effects. They cause nausea and vomiting. And if you can't get that under control, people don't go home, they don't do well, they can't participate in therapy. It's a big issue. They can also cause problems with appetite. They can cause constipation and urinary retention. So these are real issues that we have to deal with after surgery that can prolong recovery and decrease satisfaction. They can make patients actually more frustrated with the process. If they don't get back to their activities, they don't get back to what they want to do, they start to get frustrated. That can translate into depression. So there are a lot of reasons opioids cause problems. I think the way that we've gotten around that with opioids is that we just changed the way that we manage pain. And I think this is the biggest success that we've had. And it's not just the surgeons, it's the anesthesiologists and the internal medicine doctors. It's working together and saying, what's a reasonable protocol to get people through a joint replacement? I mean, this is an elective procedure, and we shouldn't be getting people hyped up on narcotics just to get them through that. And we don't have to anymore. And we've seen that. We take a proactive approach to pain control. So if you think about it, opioids, really, what are they? They're essentially reactive. You have pain, we write you a prescription for an opioid or a narcotic, a Percocet, a Vicodin, a Norco. When you feel the pain, you take it. That's reactive. We're trying to be more proactive. So at least in my practice and a lot of the places that I've trained, this starts before you even go into surgery and pre-op, where we start scheduling non-opioid narcotics. And I think that's been incredibly successful. Scheduled Tylenol, scheduled NSAIDs like Celebrex or Mobic or any of those. Scheduled gabapentinoids, so targeting different pain processes, as well as maybe a long-acting opioid preoperatively, so that when you get out postoperatively, you don't have to take these short-acting opioid narcotics. We also talked a little bit about regional anesthesia, so being able to do blocks preoperatively has been incredibly effective, I think. And the other thing is these periarticular injections that we're giving intraoperatively. So as you can start to see, we're hitting you pre-op, we're hitting you intra-op. And then when you get out post-op, rather than just giving you a prescription for 120 Percocets to take when you have pain, we're actually scheduling the Tylenol, the NSAID, the gabapentin, or the Lyrica. And so you don't even take a narcotic unless you have breakthrough pain. And in that case, we're sending you out earlier with fewer pain medications. And I think that's been incredibly successful.